Hello and welcome. My name is Alan Beggs. I'm director of the Manton Center for Orphan Disease Research, and together with Dr. Catherine Brownstein, we direct the Molecular Genetics Core Laboratory here at Boston Children's Hospital. We'd like to tell you today about the research program we're developing with the COVID-19 Host Genome Structural Variation Consortium to understand the contribution of genomic structural variation to disease severity in children. So the first point I'd like to make is that COVID-19 is a disease of all ages. If you look at these graphs of age related to either diagnosis with COVID-19 on the left or death on the right, based on data from last week on the CDC website, you'll see that as many as 10% of COVID-19 patients are children under the age of 17. Fortunately, the mortality rate in this group is quite low, less than about 0.2%. However, even these deaths are important to understand. But in contrast to the 0.2% rate of mortality among patients with COVID-19, a new syndrome called Multi-Inflammatory Syndrome in children has recently been identified as having a significantly higher mortality rate and being medically and biologically distinct from primary COVID-19. This is a syndrome that was first recognized in the United Kingdom in late April of last year, in which 8 cases, including 1 death, were reported of previously healthy children who had PCR positive COVID-19 and presented either during or soon after their COVID-19 disease course with hyperinflammatory shock and features that were similar to Kawasaki syndrome. By the middle of the next month, in May of 2020, the New York City Department of Health had identified over 102 patients with what they recognized to be a multisystem inflammatory syndrome that was associated with either prior or current SARS-CoV-2 infection. By the middle of May, the CDC had actually defined this condition in a health alert as a condition affecting individuals less than 21 years of age, presenting with fever, laboratory evidence of inflammation, typically evidence for 4 or more inflammatory biomarkers, and evidence of clinically severe illness, typically requiring hospitalization, with multi-system organ involvement, often involving either the heart, renal system, respiratory, hematologic system, GI, dermatologic, or neurological, and no plausible alternative diagnosis. In addition, to meet criteria for definition of a case as MISC, children were required to have be positive for either current or recurrent recent SARS-CoV-2 infection by RT-PCR, serology, or antigen test, or a known COVID-19 exposure within the 4 weeks prior to the onset of symptoms. Very rapidly, within the next month or so, at the end of June, 2 landmark papers were published describing this syndrome in almost 300 cases from across the United States. On the left, paper from colleagues based on a multi-center study called Overcoming COVID-19, funded by the CDC and led by investigators here at Boston Children's Hospital, and Dr. Adrian Randolph, who's a member of our research team. And on the right, a study similar size and scope from the collaborators with the New York State Department of Health. So these 2 studies really kind of helped put MISC on the map and define what it was. To understand MISC, it's important first to distinguish it from acute SARS-CoV-2 infection leading to COVID-19. So as in adults, COVID-19 in children has an unpredictable clinical course with an extremely wide clinical variation, ranging from asymptomatic carrier state to a self-limited upper respiratory infection, including mild or moderate disease treated on the wards, and at the extreme end of the spectrum, severe or critical disease that often at that point requires mechanical ventilation and or other life support. In contrast, MISC is really a post-COVID-19 syndrome, characterized, as I've said, by multisystem inflammatory findings affecting multiple organs, and typically occurs within 2 weeks to a month after infection. So in these two New England Journal studies, as many as 92% of children had gastrointestinal involvement, cardiovascular involvement in about 80%, hematologic, clotting, mucocutaneous, or respiratory involvement in about 3/4. And interestingly, as many as 40% had Kawasaki-like features involving the heart, and 8% developed detectable coronary artery aneurysms, leading to potential life-threatening complications. Biochemically, more than 90% had more than 4 elevated inflammatory biomarkers, thus meeting CDC criteria for this diagnosis. And the median hospitalization was a week, with about 80% requiring intensive care, 20% requiring mechanical ventilation, and as I said at the outset, a much greater mortality rate than COVID-19, with as many as 2% of children dying. The average age was 8, and in the New York City cohort, the 40% of children ranged in age from 6 to 12 years of age. So this is really a syndrome of children, although recently reports have been coming out of occasional adults with similar clinical presentations. Interestingly, in contrast to Kawasaki syndrome, which affects primarily children of Asian descent, there was no racial or ethnic predilection among children developing MISC. And treatment was supportive as well as directed towards immunomodulation, with as many as 3/4 of children receiving IVIG, half of them receiving glucocorticoids and IL-6 inhibitors, and another 20%. So with that, I'm going to turn it over to Dr. Brownstein to tell you a little bit about the resources we have here at Boston Children's Hospital in our project with the consortium, and tell you a little bit about our experimental plans.
Boston Children's Hospital is a 400-bed facility with 25,000 inpatient visits and over 500,000 outpatient visits per year. We are a regional referral center for New England and an international tertiary center. As of January 7th, Boston Children's Hospital has tested 42,395 patients for COVID-19, of which 1,034 were positive, and has reported 67 cases of MISC. Dr. Adrienne Randolph leads the CDC-funded Overcoming COVID-19 multi-center surveillance study, and together with Dr. Janet Chow, lead Taking on COVID-19, an international COVID-19 patient registry, biobank, and national natural history study. In June, Dr. Randolph led one of the first comprehensive studies defining MISC and describing its natural history in 186 patients from 53 hospitals in 26 states. The Children's Rare Disease Cohort Initiative, led by Drs. Piotr Slitz and Shira Rockowitz, working with the Hospital Institutional Centers for Clinical and Translational Research, banks specimens and has generated short-read exome and genome data on COVID-19 patients as part of the Taking on COVID-19. Our hypothesis is that specific environmental, medical, or genetic factors may predispose some children to severe outcomes of SARS-CoV-2 infection. Genetic factors may include both single nucleotide variations and large-scale structural variants that are not detectable by traditional next-generation sequencing techniques. Therefore, our experimental plan is to have strict inclusion criteria, including a positive RT-PCR or serological testing for SARS-CoV-2 infection, an age less than 21, and an informed consent for Taking on COVID-19, Overcoming COVID-19, or the Manton Center for Gene Discovery Core IRB protocols. We plan to enroll 50 patients each with MISC, severe COVID-19 requiring hospitalization, and asymptomatic or mildly affected SARS-CoV-2 positive patients. We will query them for structural variant detection by optical genome mapping on the BioNano Saphyr and short-read Illumina-based exome or genome sequencing. This work will provide the opportunity for follow-up RNA-seq or other RNA-based expression-based studies. We will have data sharing and joint analysis with the COVID-19 host genome structural variant consortium. And hopefully next time we speak, we'll have exciting results to share with you. Thank you.